Hello, everybody. Welcome tonight to the next conference of the Virtual Global Spine Conference, the next session. It's me. My name is Alexander Mameghani. I'm a Swiss spine surgeon located in Baden. I work in a public hospital, and this is in Switzerland. This is not Sweden. There are some difficulties, obviously. I want to talk tonight about some salvage procedures in osteoporosis. As you know, osteoporosis is really a severe burden, and I want to talk about things what we can do when cases go wrong in the wrong direction, and we need smart or complex solutions. Today I again use this Menti. This is an interactive, this is absolutely anonymous and it's free. You can just take your cell phone and read the QR code, and then you will be able to immediately vote here and give your own suggestions. What is a good option? What is a bad option? And when I run through the cases, I will repeatedly ask the audience to use this interactive tool. It's no matter where you are, who you are, whether you're a resident or whether you are a senior spine surgeon. Just feel free to use this interactive tool. I have to do some warnings. Some images may cause discomfort, but it's always, we are surprised when we see our images and we have to show these images on conferences. But it's so much better to learn from the things that went wrong than learning from these super good, super smart solutions with zero complications. So my talk is about osteoporosis, and when you screen the QR code, you will immediately be able to join this poll, this vote, and you can just use these bars and go from strong agree to strongly disagree. What is your opinion? Which condition of the patient, which burden of the condition of your patient has got the worst influence on the outcome in your daily practice? I mean, I mentioned Sweden, not because to make a fun joke, but in Sweden, the smoking rate is so low, it's like 5%. So you really, if you're a spine surgeon, you don't have to convince many people to stop smoking. So smoking in Sweden is not a topic, while in Switzerland it's really an issue. So like 30 or more percent of our patients are smokers. And so when you use the bar and you go from strongly disagree to strongly agree, what are these burdens? Some say really osteoporosis, smoking, depresses, everything. Sarcopenia and polymorbidity, not. I will stay a little bit longer on this website. Maybe you can find the opportunity to join this vote. The more people are interactive, the more fun it is. So this talk is about osteoporosis, and this is the first case. It's unusually it's a man, it's not a woman, and it's he's an artist, he's a painter, 75 years old. He has a known Parkinson disease since 8 years, and he is able to walk, but he has got massive pain. And he is bending forward after a minor fall some weeks ago. What you can see here is the MRI, the T1 sequence, and if you count, it's T11, T12. Both vertebrae are showing an edema. There are two fractured vertebrae in the TL junction. So the image here, you see the steer. The cord is, yeah, So a little bit compressed, but not too severe. You see the edema in the posterior elements nicely. The spinous process seems to be fractured as well of T11. T10, T9 look absolutely normal, and below L1, L2, normal too. So my question is, or let's have a look here to the actual view. The cord is slightly touched, but not deformed, and the patient has no neurology. So no ataxia, no spasticity. He's able to walk, and he has got a lot of pain. Of course, it's a pain that's not present in lying position, but in sitting position and walking. He can't lie straight. This is the MRI in a sitting position. It's not a lying position. This is an upright MRI because he says he can't go to the MRI because laying down is too painful. The X-ray performed here at the TL special view shows the wedge. It's a severe wedge, more than 30 degrees. And if you have this in mind, this was years ago. There was no upright standing. There was no whole spine available by the surgeon who treated the patient first. Then the patient was intubated and sedated for a better MRI. That was not in my hospital. You see the thoracic MRI, you see the lumbar MRI, and there's only this TL fracture of T11, T12 with a severe deformity. Obviously, you can correct it. My question is, if you choose operative treatment, so I go back here, where is the QR code for those who join a little bit later? You can take any device you have, a smartphone, iPhone, Android, whatever you want. You can screen the QR code, and then you can join our vote, our poll, and you can join now if you choose this operative treatment. Would you choose cement only procedures like vertebral balloons, stands, spine jacks, whatever is available, or would you go to a correction with instrumentation? As I mentioned before, this was not my. Oh, so this vote is really easy. So 100% are going plus instrumentation. No matter if you do it open MIS or if you go 360 or whatever. This is what I mean with else. It is not cement only. So if you choose post-operative treatment, I think the majority goes for adding some screws and rods and cages. I don't know. So if you choose operative treatment, and you all have chosen to doing surgery, would you go for posterior only, or would you for sure go 360? Would you for sure go anterior and restore the anterior spine as well? So this is a little bit more difficult. 100% said we go for surgery with screws and rods and not cement only. So the strategy to do everything from posterior or going to 360, well, it remains a little bit controversy. So half says that we will solve this posterior only, and the other half says it's 360. And I mean 360 for sure. If the patient has no neurology, would you do a laminectomy either way? Would you decompress spinal cord that is not compressed so much that the patient has a neurology? Means like, do you do a prophylactic laminectomy in case you restore the lordosis, you realign the spine, maybe the cord gets under compression. So again, it's very clear 20% says no, I would not do a decompression laminectomy, but I will do sterilization. And the majority says yes, I go for laminectomy. This is the MRI, and now I show you the images that have been. Oh, I go back here. Majority says laminectomy, yeah? And I go back here. This is what was performed somewhere else, and this is the post-op image, the first available post-op. With this post-op image, the patient came to me, and you can see easily that it was an all posterior combination of cement augmentation plus instrumentation. It was not MIS, it was an open surgery. Laminectomy was performed, and although the spine was straight pre-op, immediately, like 1 month after the surgery, we've had this coronal disbalance, and the patient was in big pain and was very unhappy. But as you know, when one feature is getting better, the patient says, okay, it's better than pre-op. And what was this? It was he was able to lay down in bed without severe pain. So we changed the situation from a unhappy patient with inability to stand straight, to walk, and to lay down. So he was globally unhappy. There was no position where he was pain-free, and we changed a patient into a patient who was able to lay down in bed without severe pain, but he was not able to get up. So with this image, the patient came to us, and you see here now the construct. It was pedicle screws, cement augmented, and nearly every screw was cement augmented. T11, T12, there was some cement filled in. I think we can clearly see that the severe wedge in the T-L junction has disappeared with the surgery, but there's a kyphosis above and there's a kyphosis below. The coronal disbalance is pretty seen. It's more the problem of the distal junction. It's not the problem of the cranial, of the proximal junction. So this image in mind, 3 months post-operative, we have to deal with distal junctional kyphosis, proximal junctional kyphosis, pain worse than ever when he wants to get up. The worsening of the deformity, yeah, well, I say this, it's not really fair because the kyphosis in the TL junction disappeared. The patient has got a new leg pain and an inability to walk. He was able to stand for some seconds, but not able to walk. So this is the MRI. You see now the thoracic kyphosis is not only in the proximal junctional area, there's a hyperkyphosis anyway. And in the distal situation, we see this rapid decompensation of L4-5. This rapid decompensation leads to spinal stenosis, and this is a good explanation for the leg pain. So what can we offer this patient? Here you see the axial view. This is the severe stenosis. Maybe it was pre-existing, but not severe. We had this MRI pre-op, and this stenosis was not visible. So this is a new stenosis. You see edema in the disc. It's a sign of too much forces. It's shear forces. The retropulsion of L4 against L5. There's retrolisthesis and this kyphotic angulation. You see in lying position, the neurocompression is not too severe in the central area, but you have to remember this is a lying position. And in the upright, you can see here it's a severe kyphosis. On the right side, you can easily see the kyphosis in standing upright position. So, what can we offer this patient? What would you treat surgically now? I mean, this is a patient with a bad bone quality. He has got an osteoporosis. He has got Parkinson's disease as well. And we know all our patients with Parkinson have got osteoporosis. I think you don't have to make too much measurements because maybe you find wrong high measurements in the DEXA scans. For sure, we know that these patients with Parkinson's disease have got some of the worst bone marrow densities we have among our patients. So what would you treat surgically? Would you treat only the distal junctional kyphosis? Would you do both? Would you extend to cranial because you want to treat the proximal junctional kyphosis as well? Would you only decompress? Say, okay, the spinal stenosis, albeit there is a kyphosis, I only decompress L4-5. Or would you do everything? And with everything, I mean, you will do osteotomies, realign the spine, make the patient happy again because he can get up in a balanced situation, in a balanced spine again. So now, after the first fractures, 8 months have passed until it was up to me to offer a solution. And, he was an artist, he was a painter, and he's had some experience now about spine surgery. And he knows actually that because the previous surgeon told him, you need a big surgery with lots of screws, lots of cement, and we cannot offer you a guarantee that the surgery will be a winning situation for you. Maybe the problems will remain and you will be unhappy before. And exactly that happened. So the previous surgeon was really good, explaining what are the difficulties in Parkinson's disease and osteoporosis. But the situation was really bad. And the patient had to make a decision. And I offered him, okay, we can have 3, 4 solutions. We can do everything, like an even bigger surgery than you've had before. And this was an open surgery. This was not MIS. I can tell him, okay, let's do the smallest solution and decompress only, and let's see. Or we can, and he was able to understand the difficulty, the dilemma situation. Or I told him, you can only undergo the DJK treatment with extension to the pelvis. Or you can have a combination like DJK and PJK to somehow do a semi-big surgery, but all these surgeries are big for him. So very nice. The majority says only decompression. So this was the pre-op CAT scan and MRI. You see there's some flexibility. The thoracic spine looks pretty the same in MRI like in CAT scan. The thoracic anatomy is the same. You see the tube, the tube in the trachea, because the patient was again so. He couldn't lay down in the CAT scan. He could lay in bed, but you see there is a huge angle between the thoracic and the lumbar, thoracolumbar junction and the C-spine. He was not able to lay so flat in the CAT scan or MRI, so everything was in narcosis. And you see here some fracture in L4. You can see some gas or vacuum phenomenon in L4. And what I did, because it was he said he wants to get up again. He wants to get a solution for his leg pain. I did only treat the distal junctional kyphosis, and I didn't open the whole wound. I only opened the half of the existing scar. I did a PSO in L4 took out the L4 screws, and it was able to correct the spine, and I was able to decompress the spinal canal. So this was the first post-op. You can't read German, so like me on the screen, it was lying X-ray. It was not upright X-ray. The first X-ray. So this is what I did: extension to the pelvis. I connected to the pre-existing construct, so I didn't remove the screws and the cement augmented screws. Only L4. I used a bolt cutter to cut the rod, and it was not my recommendation only, but I offered the patient several, like I presented him options, and he has chosen the smallest meaningful solution for him. So this was his decision, and I think this decision was okay. So this was the line. You can see here now how I did the connection. I used the bolt cutter to cut between L3 and L4, did a PSO of L4. And in an osteoporotic spine, a PSO is something different, like in a post-traumatic deformity of a young patient. So sometimes you need to chisel, and it's a hard bone in a fixed spine when the bone quality is good. When you have a weak bone like this, like the patient has, it was really easy to do this PSO because whatever instrument you were using, the bone is so weak. It was sometimes I thought it was like cutting butter. So it was good that the previous surgeon did an augmentation of L4, because in the anterior part of L4 there was some cement. And when you look to the next slide, this pre-op and post-op, you see the on the right side the pre-op images, the LIV screws. I took them out, and this cement inside of L4 now acted like a good stability of the anterior part of L4, and this was a really extensive PSO. The patient was able to walk again, had no leg pain, and then after the surgery, I told him that we can stage the surgeries. It was not too long. The surgery took like 4.5 hours. He was willing to do the proximal junction kyphosis again, because then he wanted to stand up straight. So this was his intention now after the first surgery. When you remember how big the complication rate is, sometimes it's astonishing that these complex surgeries work out so well for the patients, although the patient is so sick. This is the standing X-ray whole spine. He was now able to get up. And I ask you, would you as a surgeon recommend further surgery, or would you tell the patient, you've had so bad luck in the first surgery, and then you've had good luck in the second surgery, let's call it a day and don't go any again into the OR? Would you say it's enough, or would you say let's do it and let's go for another surgery? So this is my question to you, and I think one colleague says yes. Let's go for the next surgery. So let's say when the patient says, I want this surgery, what would you do? We've had some time, because the wife was diagnosed of renal cell cancer. She was my patient as well. And so he wanted to wait. He wanted not to stay in hospital, undergo risky surgery. He wanted to stay with her wife, which is really a good situation for me, because I could make some plans. Where would you go now if the patient says, I want to have my proximal kyphosis, my hyperkyphosis treated, because you know the Spinal alignment is not good. The SVA is like 15, 20 centimeters. I couldn't solve the problem with a osteotomy in L4. The PSO is not a weak, is not a strong tool to correct this spine. So 3 say, yes, I would go to T2. And please, if you don't want to go to T2, say no. Just use the cell phone and say no. It's nice if you leave your vote, because I ask another question in the next slide. Just wanted to hear, if you look at this spine with a big SVA, an undercorrection of the lumbar spine, an undercorrection of the TL junction for sure. Where would you go? So the half would stop at T2. Thank you all for voting. It's fun. Now I ask you, would you go to C2? This is the same situation. If you go here back, 3 say yes, 3 say no. Who would go to C2? Who would go in the high cervical area? Haven't shown the cervical MRI, which was without any stenosis, without myelopathy. Who would go to C2? If you don't want to go to C2, say no. If you say yes, I would go to C2, please say no. Okay, so the vast majority, nearly everybody says no, I would not go to C2. So the patient waited, and he waited 3 years. So he was 3 years in a disbalanced spine, but here the coronal deformity was solved. So he was not bending a lot to the right side like before. And one colleague says, yes, thank you. He waited for 3 years. His wife passed away, unfortunately. And then he was a widow. Then with some more freedom, he said, I want to do more. I'm an artist. I want to go back to my activities. I want to make some journeys. I want to paint in the environment. And 3 years later, maybe you can see the dates from 2020 to 23. On the right side, it's 23. We've had these osteoporotic spine in the Parkinson patient, and now something happened, but it's happened not in the PJK area. And this is why I wanted to show you these images. This PJK stopped to decompensate, and something new happened in the cervical-thoracic junction. So this chin on chest deformity he developed was not due to the burden he had in the PJK after the first surgery. And here you can see in the AP view the chin on chest deformity, not only a kyphosis, but also severe coronal imbalance. Now the patient said he's very unhappy with the situation. All these orthopedic surgeons among you will also notice the severe hip osteoarthritis on the right side. He would need another hip surgery as well, because this hip is aching a lot. The orthopedic surgeons also notice the difference in the shoulders. The right shoulder is with the cuff arthropathy. So he was everything was aching. And suddenly I got the call 1 week before the next appointment that the patient suddenly died. So this is the last image I can show you. This is my first case, and this is where this case ends. I just wanted to show you these cross connectors. I think they are universally and globally available. But I love these cross connectors so much because I can stage so many procedures without extending or opening, reopening the whole scar. You see, this patient underwent a laminectomy. When you go again into a thoracic spine with three or two laminas missing, I don't like this as an orthopedic surgeon. I want to stay away from these dangerous areas. And so I just want to mention that these cross connectors are really workhorses in my daily practice. So stage procedures, I like them a lot because I can reduce some risks. This DJK surgery, okay, some of you will manage this in 2 hours, I know. I need more than 4 hours for these. And when I do both, like DJK plus PJK, overcorrect the spine, these are long surgeries, really long surgeries. And stage procedures are nice for the sick patients, for the frail patients, and I can really meet the patient's expectations. What do they want? Um, what is small enough? What is big enough? What does the patient allow? Patient's health allow? Stage procedures. I do many of them. So case two is something different because she's a woman. She's 77 years old. She has a known severe osteoporosis. She's under medical treatment for years, since years, and she has a single level degen spondylolisthesis. I treated her pre-op for 5 years, did some injections, field therapy, and but then the pain was getting more and more severe, back pain plus leg pain. She then was immobile. She came into hospital by emergency, and so injections didn't help. I show you the osteoporosis, the DEXA. She was 77 years old, and albeit she gets really good medical treatment, the bone marrow density is getting bad. And it's getting worse. So she's less than -2.5. This is the MRI. This is the medial SEC2. This is the Ali Baj, Dr. Ali Baj, Professor Ali Baj view. He needs this for most of the decisions. But I want you to show you some more images. And so this is the axial view. And maybe you can see here why the pain is so severe, the right-sided leg pain, because it's a huge compression here visible, the flavum, but you see the slip, you see some effusion in the joints, not too much, I've seen worse. And this is the lying MRI with the foraminal stenosis visible of L4. So when I ask you, and please use this smartphone and join. Is this a very bad bone quality on the X-ray? You can see only one fracture. This is T12 fracture years ago. Is this slip? Can we fuse the degen spondy L45? Is this only manageable with cement, or can we do other? Have you got other options than cement, or is this a hands-off spine? We should not touch this spine as a surgeon. So I would love to hear your comments, whether this bone is bad quality. I think this is the impression of the X-ray. I've shown you the DEXA scan before. Silly me, it was my fault. I wanted to show the DEXA scan later and ask you by judging the X-ray. We are always bad in judging the bone quality in X-rays. This is my opinion. Even on CAT scan, what is a good bone, what a bad bone. But you can see here nicely that the gray scale of L4, the anterior cortex of L4 is somewhere vanishing into the prevertebral vessels. So, okay, the bone quality is bad. Strongly agreement. Feasible to fuse, not so strong, only manageable with cement. We have a tendency to agree. And a hands-off spine, only one or two say it's a hands-off spine. We should not touch this spine. So this is interesting. So fusion. If we have to fuse L45, please say true or false. Is this possible without a cage, or do we have to use a cage? Do we have to use a P-lift or T-lift or X-lift or A-lift, or is this manageable without cement? Can we fuse an osteoporotic spine without cement? Or is fusion a bad option for her? This is my question to you. And you can see now, very easy, there's no majority to fuse with or without cage. There's no majority to fuse with or without the help of using cement augmentation. And fusion is a bad option for her. The majority says yes, fusion is a bad option for her. 5 of you say not a good option, is a bad option. So if you want to use the Norwegian RCTs, you're absolutely right. In a degenerative spondy, the decompression alone will help. But she has back pain since years, and I'm an orthopedic surgeon, so this was before first days after surgery, and I did the fusion. Everything looked so fine. It was really fine. She said, "Thank you." Until something happened. So these are my post-op CAT scans. I always do them. I did a posterior lateral fusion L45. You see a lot of bone between the transverse processes. You see the drain. I used a drain that time. This is some years ago. And you see I didn't use any cage. The CAT scan in the 3D reformat shows a little bit where I put my screws. So these are my screws completely in the pedicle. There was no breach to the medial pedicle wall. Yes, if you look at the left one in L5, you will see, okay, it's a little bit lateral. And you can see in the reformats where the hard bone is in the posterior elements. And that time I didn't use any cortical bone trajectory. This is the case, a reason why I went over to the cortical bone trajectory. And you see the screw is completely in the cancellous bone. And we know the cancellous bone is the weakest. So when I ask you now, the cage is missing, who says true, the cage is missing, or posterolateral fusion is a valid option? Who says the cage is not missing? Please help me. I didn't use a cage, and can you judge me, please? Can you just say no? The cage is not missing. Posterolateral fusion is good. Let's have a look into the history. Like we've used the spine and the degen spine since, let's say 1980, like 40 years, and the interbody fusions is getting standard of care since, let's say 20 years. The cage is missing, not true. Thank you so much. You're so kind. And who says, I mentioned before, the screws are too lateral. Please feel free to criticize the screw placement. By me, it's a navigated screw, by the way. The perfect screw length didn't touch the anterior cortex, but is a little bit lateral on the left side, for example, maybe on the right side as well. Please feel free to criticize the screw placement, or do you do the same? Thank you again. The majority says not true, not too lateral, but me, I said it's true, it's too lateral. When I've seen the post-op X-ray, I was a little bit unhappy and said, "Oh, too lateral. Hopefully, the vertebra doesn't break." And then after surgery, after several days, there was a fracture. You can't see it very nicely here on the CAT scan, but the anterior cortex is broken, and you can see here the breakage on both sides of the. It was a cranial incomplete wedge fracture, and the patient was in severe back pain. This is a unhappy situation for me. This fracture of L5 in an osteoporotic spine. This is something I told her this can happen. I didn't use cement. So let's discuss my my failure of not using cement in the end. But now, what would you do in case of surgical revision? Would you use cement and over augment the lying screws? Would you go back to the OR, take out the rod, and put cement in? Would you go to the ilium? Would you extend caudally to S1? Would you do it? Or would you stay on L4-5? Would you extend cranially too? Would you go to L3 to make the construct bigger and more stable? Or would you go back and insert cages? This is what I want to ask you, and please feel free to use the bar if you're not sure, to strongly disagree, stop at any number. If you strongly disagree, just put the bar on the left side. So I will wait some seconds longer, because I want really to know from you who is only doing the over augmentation of L4 and L5. Just be the smart guy and use cement to redo, or no, to correct the failure, the mistake of the first surgery, because I should have used cement in the first surgery. For sure, I should have used cement. Oh, nice. Thank you very much. I think the use of cement is, yeah, many will use cement in L4 or L5. The majority would like to go to the ilium or S1. So controversy between extension cranially. Some say yes, some say no, and the cage is not really the solution for the majority of you. So what did I do? I used some cement, and I did it with a lot of confidence that the secondary cement augmentation can solve the problem. So here I used I always use fenestrated and cannulated screws. So I put in some cement. The cement is a high viscosity cement. It stays into in the vertebral body, and I can rely on this cement. It's not going anywhere. And this is the SAC in the CAT scan, the sagittal reformat. You see a little bit of cement in the middle of L4, but laterally surrounding the screws, a lot of cement in L4 and in L5 too. You can see the vertebra is filled from anteriorly cranially to laterally caudally. It looked really fine, and the patient was happy. So this is a good solution. But 2 weeks later, the whole L5 body that was augmented with cement collapsed. So despite I put in a high viscosity, strong cement, it was many milliliters, like 5 milliliters in L5. Although I used a lot of cement, this L5 collapsed. And I didn't I was not able to send the patient to rehab in this painful situation again. Some L5 radiculopathy, as you can imagine, because the posterior wall in the lower part of the vertebra is compressing the L5 nerve root. This is the MRI. You see the cement of the from the CAT scan in the middle. I go back some slides, like here. This is the L4 cement in the middle, where the basivertebral vein is maybe filled a little bit. And this is the MRI 2 weeks later, when L5 collapsed. So this is what I wanted to show you. There is a difference between cement augmentation of an intact vertebra and cement augmentation of fractured vertebra. These vertebrae are not the same. They behave differently when there is a weight, when there is a force compressing the vertebra. While L4 stays absolutely intact, and you see nicely L3-4 is intact too, L5 collapsed. So these are some lateral views. The foramina are free, not too much compression of L5. This is the T1 for in case of a radiologist is watching. So the smallest solution didn't work. Too many enemies, osteoporosis, fracture, 2 lateral screws, no cage. I missed the opportunity to extend the construct. When I ask you again now, what would you do now in this situation? Would you now extend to S1? Would you extend cranially? I changed the option of staying in L4, L5, and I replaced it to even a bigger surgery. Would you osteomize L5? Would you realign the spine? Would you do an even bigger surgery? So the first votes are coming in. I will vote 2 because I will vote for this, what I did. And would be nice if you use the vote, the poll, and say what you think, what is a good option. So some votes are coming in. 5, 6. Okay, everybody would go to or agree to extend to S1 or ilium, and some are going. No, the majority says don't extend cranially. Yes, maybe one colleague is saying yes, extend cranially, and the cages are not an option for the majority. So what did I do? I stayed in L4. I didn't extend cranially, but I went to S1 and I used ilium screws. And this is a cross connector between or under the screws of L4. This is a standing X-ray. The patient is able to get up, but is a little bit unhappy. 1 month later, you see the construct is not working too good. The patient is lying. This is a lying X-ray, and a month later, L3-4 has got big changes. The lower part of L3 is fractured. The disc is collapsed. And this is the MRI. There was no infection. The blood sample was good. This patient has never had any wound healing problems, never had an infection, although some parts of the MRI are suggestive of infection, but there was no infection. And here you can see the T1 is a big edema, not the whole body, only the lower part. And you can easily see the problem is now L3-4. Just a short question, only 1 level up, or would you go more level ups? What would you do? Please answer with this easy decision, yes or no questions. I posted several weeks ago that yes or no questions are the best questions we can ask. Decision making is something we always have to do as surgeons, and I can't go up 1.5 level. I can stay one level above, or I can extend a lot. So one level up, only two. Colleagues say one level up, and most of you say no. So what I do, I did one level. I went one level up, cement augmentation, and this is the X-ray. See the measurements. If you see 3 months later, if you see these pre-op lumbar lordosis and the post-op lumbar lordosis, it's just measurements. Yeah, the patient always have to do a hyperlordosis of the levels L1, 2, and L2, 3. So lordosis is not a good parameter to judge a spine. This patient has got an imbalanced spine, and the compensatory mechanism of L1, 2, and L2, 3 have always been at max. Pre-op, if you judge the pre-op lordosis, like 60 degrees, looks so nicely 60 degrees, but it isn't. It is very so maximal compensated lordosis, because L4-5 goes into kyphosis. And this is really a problem with these parameters in the osteoporotic spine. So you can see nicely the imbalanced spine, that the patient is just too frail to undergo a big deformity surgery. She went through a hard time. She couldn't go home. She went to a nursery home for months, recovery, rehab. It was a really a difficult road for her, and she said, I will never undergo any spinal surgery again. But on the other side, she was really thankful, because she always remembered how big the pain was, and that she was informed that surgery maybe is not the solution. So 3 months later, after the extension to L3, and this is the X-ray, and you can see the next fracture is happening. L2 gets broken 1 year later, and this is the MRI, the next collar fracture. And I told her, because there's no neurocompression and she's able to walk, I told her, this situation is unlucky. Now you can see, although the best medical treatment is applied, like Forsteo and all these new stuff, this was before Evenity entered the market, the next fractures are there. L2, L1 is fractured, T12, everything is fractured. And we both agreed to not go into the OR again. And the patient still lives. She's still my patient, and I want you to ask, because you can only ask one. You can only choose one option. What is the reason of failure? Why did the patient not do well? Well, this osteoporosis is a natural course of osteoporosis that we see. Is this sarcopenia? Is this frailty, or is this the surgeon's mistake, if the surgeon wouldn't have chosen to offer fusion, just decompression? Is this the problem, why this spine collapsed? So thank you for using this poll so much. I really enjoyed your participations, and I think you both options are correct. I think frailty is the reason. You can't see the patient in life. I don't have any. There's no chance. You have to trust me when I tell you, but I did know her for 5 years, and I think I overlooked how frail she became. And when she entered the hospital in an emergency situation, so much pain, she was frail. This was maybe more a psychosocial reason why everything was so bad. And it was not the osteoporosis, in my point of view, when I analyzed this case in retrospect. It was not sarcopenia. Everything came together, and I could not recognize her again after the first surgery, after the first revision, because she was so frail, she was so weak. She was mixing up all the details. She was confused and she was depressed. She didn't eat. It was so hard to feed her and to get her back into physical strength. The rehab, which usually lasts for 3 weeks, took months of physiotherapy. She was in a nursery. Everything was so bad. And this, what we call frailty, it's not the bone weakness alone. It's this whole bundle. I've had no chance. I've completely overestimated the general health of my patient. And after the first revision surgery, I recognized this will not lead to a happy end. Today, she's happy in her home again. She left the nursery home and she's back at home. But it was really hard for her. It was a tough time. It took her more than 1 year to recover. And this is why I share this case, because we don't measure frailty so well. We don't measure sarcopenia so well, but we measure a lot of osteoporosis. And there's a big difference between a 52 years old patient with osteoporosis and the DEXA, or patient who is 77 years old. This makes a big difference. So I just want to say thank you to everybody. I'm just looking, the chat box is full. Sorry, I couldn't read during my talk, but now I'm able. So thank you, Wendy, for your smiley. So frailty, yes, Wendy, you're right. Frailty is my final opponent. You know, in all these computer games, you're going level by level, but then there's this super hard opponent in the end, and frailty is my final opponent. You have no chance as a surgeon. This is the reason, mostly my reason number one to refuse to offer surgery, especially deformity surgery. Bracing, yes, bracing is a good thing. I tried to convince her to use a brace, but the brace was aching everywhere, at the pelvis, at the thoracic. So we tried a brace, but it didn't. We didn't succeed with this. So thank you very much for your participation and listening to these cases. It's now midnight here. It's I think 11 o'clock in New York time, and it's I don't know, it's 1 o'clock in Saudi Arabia. It's so nice that you participated in my votes and the polls, and I'm happy to see you all again next week with the next session. And please have mercy with me. Just showing these cases, which are really challenging. And I stopped. I didn't do the full realignment of the spine. These should be presented in the deformity sessions. Today was about osteoporosis and the attempts to solve problems when osteoporosis and fractures hit your patients. Thank you and goodbye. See you next week.